Good morning. Teaching and learning communication skills in Iraq using feedback in a simulated environment. I am Dr. Abdulsalam Sultan, Senior Lecturer at Al-Kindy Medical College. Al-Kindy College of Medicine introduced experiential learning and teaching of communication skills for the first time in the academic year of 23-24. The curriculum was started in 3 academic years, the first and second with early clinical exposure module, and in the 4th academic year with a primary healthcare module. The training on medical interview in the 2nd and 4th academic year. And there is a 15 hours training on medical interview in the 2nd and in the 4th academic years. So we have 30 hours training for the first time introduce communication skills. And we, in the future, will include all the levels of undergraduates in teaching and learning communication skills. The medical interview training divided into 2 parts, large group lecture and small group lecture. The large group lecture, the expert, the communication skill expert, explain the medical encounter framework as shown in this slide, which we depend on a Calgary Cambridge guide with a modification for more simplification of the framework. We put the respect of the patient as a principle over all the steps from opening the session to the closing the session, and in parallel, the verbal and non-verbal skills are skills used to in all stages steps of medical encounter. After the communication skill expert introduced the encounter framework, he supplied the student with a written scenario on one step of encounter in each lecture to be discussed. And they will identify the skills used in the scenario with a checklist. Then he presented a trigger tape, a pre-recorded medical interview of the same scenario to show the student how the communication skills are presented and demonstrated to enhance understanding of the using of the skills in real practice. Then the student moves to a small group learning with a facilitator. Because of limited resources, we use role play as a primary learning tool. The facilitator identified the objectives of the session and explained the roles of the students. And at the end of the session, he ended the session with a closing remarks. The students are divided into trios, doctor, patient, and an observer for practice the rules in turn. They use their mobile phones to record their interviews. At the end of the session, some students demonstrate their interviews for observation and feedback. Due to the large number of students, there is little room for the student to rehearse feedback notes given by his colleagues. Students are encouraged to rehearse at home and submit a recorded interview for assessment to every part of the encounter. The feedback, we use ALUBA, agent-delayed outcome-based analysis. We start to supply the student with a checklist to ensure that all the necessary skills of the observation are covered. The initial reflection is about the student who is acting as the doctor. And we ask him 2 questions about his performance. What were your main goals and what challenges do you encounter? Here, the student will we will see the student if he was able to recognize the problems he was facing, and to assess that the student can suggest an alternative solution for the specific problems which he is identified. Then we move to then he will practice this alternative solution before we seek help from the group, and the student should ask the group about the assistance, what he wants them to help him in what problem. The group involvement, they should encourage to see the interview as their own interview and find the solution as if they are acting as a doctor. The group feedback should go in rules, and the facilitator should have a strict rule. The feedback should be a constructive, good intention, descriptive, and focused on specific instance rather than generalization. Here, the mastery of the facilitators will appear that there is some disturbance will happen in the group, and there are some laughs and jokes and tension between among the group. So the facilitator should ensure the feedback to be an actionable and promotes growth and improvement of the performance of the student. Finally, I will talk about some Arabic culture specificity in feedback interaction. In feedback interaction, there is some specific problems in Arab culture, like family members might be involved in feedback. Instead or with or against the patient opinion, their feedback might be conflicted with the feedback of the patient. And this is a very problematic during the encounter. The feedback might include cultural or religious belief, which is hard to change. And because of high respect of authority, some students underreporting of dissatisfaction of comments of facilitator, and they use indirect emotional feedback in nonverbal cues. Modesty, some female more than male students may avoid discussing certain issues openly and leading to incomplete feedback. And some patients, even some doctors, might avoid providing feedback on some sexual or mental issue and many other taboos in our society. So feedback is very essential, training and improving in medical education before the doctor will go to practice. Thank you very much for your listening, and please enjoy the rest of the workshop.